She is a 72-year-old lady who has this posterior polar cataract. The entire lens, only the posterior pole, is affected with the opacity. Although there is not a classical onion peel appearance, but I would like to treat it as an posterior polar cataract and take all the necessary precautions which I would take for a posterior polar cataract. I've also got the lens OCT done for this patient, in which there is no evidence of any pre-existing breach in the posterior capsule. The surgery is being performed under posterior subtenuous anesthesia. The patient is slightly anxious and sensitive to pain. 2 side ports are created. The anterior capsule is stained. Care is taken not to overpressurize the anterior chamber. The OVD is always kept just enough to maintain the chamber but never to overpressurize it. Main incision is created. Now is the time to perform the rhexis. My plan is to perform an oval rhexis, which I have been mentioning quite often, and I have been using it regularly for the posterior polar cataracts, which I learned from Dr. Kiranjit Singh from Amritsar. I prefer to have the longer diameter of the rhexis parallel or in line with the temporal axis, so that it gives me easy access to the subincisional epinucleus and cortex. So no hydrodissection is to be performed. I'm going to go ahead with the sculpting itself. I'm ensuring that the bottle height is kept low. Look, the pressure is around 40. Should be fine. I'm using lower continuous torsion energy to create a central groove which is long enough. Since the nucleus is relatively soft, a couple of strokes get me to the right depth. Now is the time to perform the inside-out hydrodelineation. Now is the time to go ahead and try to divide the nucleus. Using the Sinskey hook and the phaco handpiece, they're placed in the depth of the groove, and then a lateral separation maneuver ensures that we have got 2 halves. Now care is to be taken that we don't rotate the nucleus and manage the nucleus without rotating them. So now is the time to manipulate these lens matter and bring it into the center of the capsular bag and then emulsify. Since the nucleus is very soft, it's quite challenging to get hold of those pieces. So I'm using my second instrument, which is just the lens dialer, to scrape off the endonuclear material and then feed it to the phaco handpiece. So basically the endonucleus is being consumed layer by layer. The heminucleus on the right side, which is subincisional, is maneuvered out of the fornices of the bag by using the second instrument, and then it's emulsified. Time to emulsify the second heminucleus. Again, the distal part of the soft endonucleus is easily maneuvered and aspirated by the phaco tip. I'm finding it difficult to maneuver the proximal half of the endonucleus on the left side, so just before coming out, I inject OVD to ensure that the chamber does not collapse. The chamber is refilled with OVD, and then using my second instrument to the opposite side port, the proximal half of the heminucleus on the left side is just maneuvered out of the fornices of the bag and now is ready to be consumed by the phaco tip. The subincisional epinucleus needs to be displaced out into the center of the pupil, and it is done by injecting viscoelastic underneath the epinucleus through the oval rhexis from the main incision. This helps to displace the subincisional epinucleus to the central part of the chamber, which is then aspirated with the phaco tip. So during the entire phase where phaco was used, whether to remove the nucleus or the epinucleus, the pressure was always maintained 40 or less than it. So overinflation or overpressurization of the chamber was consciously avoided at every stage. Now is the time to remove the cortex. Even during cortex aspiration, care is taken to ensure that the bottle height or the intraoperative pressure is not very high. You can see that we have kept it at 34. Carefully and steadily, the cortex is aspirated without compromising on the chamber stability. The hands are switched. The remaining cortex on the other half is aspirated out. Time to implant the lens. Chamber is inflated with the viscoelastic, and the planned hydrophobic single-piece lens is being implanted into the bag. OVD both in front and behind the lens is aspirated out. So these are the first day post-op pictures and the patient continues to do well. To summarize quickly, I am currently following the 2-point strategy. The first principle is to ensure that at every stage of the surgery, we're maintaining low pressure, which is what I call low pressure, low flow surgery. There's low infusion pressure. We're working under low infusion pressure. That also includes that apart from the bottle height, which is kept low, even when we're pressurizing with viscoelastic, care is taken not to overpressurize it. Until the end of the surgery, even during side port inflation, care is taken that the pressure is not built up. Raised infusion pressure is the most common cause for spontaneous rupture of posterior capsule. Number 2, I'm preferring to use the Oval Rhexis of late now in most of my posterior polar cataracts. This helps me to have easier access to the subincisional epinucleus part, and this is the part which we usually struggle, and excessive stretch or maneuvering to mobilize the subincisional epinucleus would be the common reason for posterior capsule rupture in these vulnerable eyes. Hence, Oval Rhexis does help. So that was it. Thank you for your attention and hope you found this helpful.